Hi guys, this is Sharda here. Hi all of you. Good evening. Hi, today we are talking about space infections. Basically we are discussing two main topics in oral surgery. Okay? So I guess you've already done with 1 or 2 classes of oral surgery, right? Yeah, okay. So it's two small topics. So basically when I talk of space infections, we'll cover some part of anatomy also. Okay? Yeah, good evening. Okay. So before I start off with the space infection and preprosthetic surgery, I want you guys to tell me whether everyone knows or is familiar with all the terms that we have learned, like vestibule and sulcus and infratemporal fossa and all of that. You guys are comfortable with all of that? Yeah, so whenever I talk of say labial vestibule or a lingual sulcus, or genial tubercle or anything of that sort, you should be able to imagine. I have pictures for you, but it's more of a three-dimensional imagination what matters. Okay? Okay, so let's begin with space infections today. Hi, so just let me know whether your audio and video is fine. Okay? Okay, so I'll go to the first slide. We're doing space infections first. Okay, so basically when you talk of spaces, right? Good evening, Kirti. Okay, so when we're talking of spaces, what the main thing is, we don't actually have spaces in between the tissues. Okay, that's what I want you guys to understand. When we say facial planes or say submandibular space or buccal space or canine space, it's not that between the two tissues you're actually having space. Okay, it's basically what you have two, may say, layers, okay, and in between you're having certain loose connective tissue. Okay, you have certain loose connective tissue in between. You can have your veins, your arteries, your nerves, etc. Yeah, Prasad, tissue planes. So when we say spaces, it is not an anatomical form that exists in our body. Moment you say buccal space infection or buccal space, it's something to do with the pathology. There is something wrong because of which there is no. Okay, it's not given in the keynotes? Okay, so just note it down or write it down. Okay, basically when we talk of spaces, we are not talking of it as an anatomical landmark. It's not normal. It's not normal like your, say, submandibular nerve or any other artery or vein. There is no empty space. You have something in between them. You have connective tissue, you have your nerves, arteries, veins. Okay? What happens is when you have an infection, it might be odontogenic or it might be some other infection. The microorganisms tend to go and spoil the hyaluronic acid that is present. Right? You know that the cementing part of any two cells is mainly hyaluronic acid, right? Yeah. So what happens is, the most famous example that you know of is streptococci, right? It tends to break down your hyaluronic acid, that is a cementing material for two cells. So it gradually breaks down the cells, breaks down the connective tissue, okay? It engulfs your arteries or veins or whatever they're present in it. And that's how you realize that there's actually that space in between the two tissue planes. So next time on, whenever you talk of spaces, you use the word as potential spaces, because these areas are potentially spaces. Whenever there is a chance of an infection spreading, they become potential spaces for the spread of infection. Okay? Okay. So the head and neck region has a large number of facial spaces. These spaces are bound by the fascia, which may stretch or be perforated by purulent exudate, facilitating the spread of infection. Okay. So we move on to the next slide. These spaces are potential areas. See, that's why we call them potential. There is an ability for infection to spread through these areas. They do not exist in healthy individuals. Okay? So you know the different kinds of spaces, right? You have buccal, buccinata, parapharyngeal, submandibular, all of these. So we are going to go in detail into each and every space and in relation with the anatomy. Okay? So here it is in general. Okay, so concentrate on the diagram. Can everyone see the slide now? Yeah, okay. So here it is. Now when you take a cross section, right? What do you find? You find, see, this is your vertebrae. Can you make out? Right? This is your vertebrae. This is the prevertebral space. The word itself suggests, right? It's before your vertebral column. So it's a prevertebral space. Then you have something known as the alar fascia. Okay? We'll come back to this. I have a question for you. It's from MCQ point of view. Let's go through all the spaces in this diagram and I'll ask you a couple of questions. Okay? Okay. So for now, you know, this is the prevertebral space. This is the alar fascia. Okay? This surrounding, can you see this? Right? You have your common carotid artery, internal jugular vein, and you have your vagus nerve. So that has to be a carotid sheath. Okay, when you talk of, yes, Pani, it's a carotid sheath. So that also acts like a fascia. Right? It's just a covering. Anything covering becomes a fascia. So that is your carotid fascia or carotid sheath. Okay? Then you have your pharynx. So see, this is the tongue, right? So behind this, the pharynx is there. So you have the retropharyngeal space. You have the retropharyngeal fascia, the retropharyngeal, buccopharyngeal fascia, the retropharyngeal space here behind the pharynx. Okay? Yeah, so here you have your mandible, you have your parotid gland and, okay, medial pterygoid muscle and all of that. So basically now in this diagram we are seeing the spaces or facial spaces that are behind the posterior most area, okay, right in front of your vertebrae. Okay? Okay, so now you know these three. Now I'll tell you the significance. Okay? Now before I tell you I'll give you the questions or ask you questions. Everyone knows what is mediastinum, right? You can, you want me to type it? You know what's mediastinum. Yeah, so what exactly is it? Can you guys tell me what exactly is a media? We have heard it, right? Mediastinal space, posterior mediastinum border, anterior border, everything. So what exactly is it? Can anyone tell me what exactly it is? Part of the thorax, yes, Kirti. Yeah, Roshni, but there is a slight difference. Okay? See, when you talk of mediastinum, imagine it to be a bag. Okay, in India, mediastinum is a non-delineated group of structures. So basically imagine it to be a bag, okay, which is very closely associated with your lungs. It's present inside your thorax, and it has everything in it. It has your heart, okay? It has your main vessels to the heart, okay? It has your trachea, your thoracic duct, okay? All the main structures. Okay? So basically it is in the middle part. But what you need to know is it does not include your lungs. Okay? Lungs are separate. Lungs are covered by your pleura, pleural cavity, etc. So it basically, just imagine a cover or a bag which has your heart and everything a little bit in the midline. Okay? Sandwiched between your two lungs. That becomes your mediastinum. Now why I am talking of mediastinum is, it goes all the way up to your diaphragm. Okay? It's in contact with your vertebrae posteriorly, it's in contact with your sternum anteriorly, it's in contact with your lung. So all the important structures this mediastinum is in contact with. So what happens is, there is something known as the danger space. Can you see this in the diagram, what I am pointing out? The danger space, okay? The danger space is usually found between this prevertebral fascia, the alar fascia. Okay, the reason being, what happens is this alar fascia goes way down to the posterior mediastinum up to your second thoracic vertebrae. Okay, it goes way below. Because of which, if you have any infection here in this region, it will directly go to the posterior mediastinum. From there, it will go up to your second thoracic vertebrae and can damage anything from your lungs to your pericardium to anything. Right? So that's why it's known as the danger space. It directly leads you to all the vital organs of your body. Can India? I'll repeat it. Last point. Okay. See, can you see this space? This is the alar fascia, right? And this behind is the prevertebral fascia. So, in between this alar fascia, okay, envision it going down like a sheet. It goes down all the way to the posterior mediastinum. This is at the neck level we are talking about. Alar fascia. It goes all the way down and it joins or merges with the posterior mediastinum. I told you mediastinum is like a bag, right? Bag should have all sides. It should have anterior, posterior, sideways, top, bottom, everything. Right? So when it goes all the way in between your lungs up to your diaphragm, this mediastinum, we are talking about the posterior wall. This alar fascia is in continuity with it. So if your, say, cellulitis or edema goes through and through, what is going to happen? It's going to come in direct contact with all the structures of your mediastinum, which is heart, and sideways mediastinum is also connected to the pleural fascia or your pleural sac, right, which has your lungs. So it can go through that also. Median raphe is not there. No, median raphe, when you're talking of median raphe, you're talking about it anteriorly. I'm talking of the fascia here. You're not going to have a median raphe which is going to cut through your fascia. Got it? See, fascia, that's why I told you in the beginning, we're talking of potential spaces, right? So what I'm trying to tell you is, ultimately how, see, all you guys know what is buccal fascia, canine fascia, everything, right? Buccal space, canine space and all of that. Now what I'm trying to tell you is, imagine all these spaces are connected and they go down ultimately to the mediastinum, and how they are connected to parts below your neck. Ultimately, see, whenever we say your facial spaces infection can become life-threatening. Why do we say they become life-threatening? This is the reason. Some of them, now I'll give you another example. You have your carotid sheath, right? That acts as a potential space. Now, why do we say carotid sheath can be dangerous? The reason being, on top, okay, let's move on top. The carotid sheath contains your internal jugular vein, your common carotid artery, everything. Where does that come from? Carotid canal, right? Carotid, so something to do with the base of your skull, something that's entering your skull. So on top, this is going to enter the skull, and below it's going to go all the way to your heart. It's going to ultimately merge into your pericardium, which is again a fascia that is going to protect your heart. So anything that goes wrong with this carotid sheath, it's going to go spread in both the ways. It can go right up to your skull, maybe even cause meningitis. I'll come back to meningitis. And downwards it can go up to your heart. Agreed? So that way, when you talk of facial infections, you have to think of it in a broad view, where all it can spread. It's not just restricted to your head and neck. It can go anywhere. The main reason being, ultimately, all these potential spaces are interconnected. Either they are adjacent to each other, or they ultimately join one another. Like I said, this carotid thing is ultimately going to go and join your pericardium, the sheath. Not the structures. We are not bothered about the structures inside them. We are talking of the coverings. Okay? Okay. So coming back to the main point, always remember when they talk of the danger space, right? It has something to do with your alar fascia. And remember it this way, the alar fascia is present in close proximity to your prevertebral fascia, and it goes way down. It goes to your posterior mediastinum. And when you talk of posterior mediastinum, just remember that it's like a sac, and it is going to go ultimately to all your heart, adjacent lungs, diaphragm, even your vertebral space, everything. Okay? Another interesting fact about your alar fascia is, if you observe, this is your vertebrae, right? You have your prevertebral fascia here. So when you remember, try to think of the vertebrae as in a lateral direction. Okay, you have certain projections, right? The vertebral, the body projection. It's not going to be like a smooth, like a cylinder. You're going to have those spaces between the vertebrae. So what a prevertebral fascia does is, it just covers up your vertebrae. What alar fascia does is, it's going to cover this space between the first and the second vertebrae, second and the third vertebrae, make it smooth. Understood? Yeah, so you can imagine it, right? How it's going to be? Okay. So between, like if you have a fascia that is going to cover up the holes or the spaces in between the vertebrae, trying to make it one smooth column. Okay, so that's what is alar fascia, and it's going to go way down, and that's how it's going to affect and becomes the dangerous space. Okay, that is one example. Now we move on to the next slide, okay, where we are going to go through the fascia one by one. Fine? Okay. So now, this is the next slide. Okay? Can you see the slide? Are all these present? Naren, I'm not sure, because some of them I have added at the last minute to the PPT. I just wanted you to understand this. It's not more of a fact base as it is for you to understand. Okay, you need not by heart it. Just when you think of alar fascia, remember why it is present. It's not there. Okay, Anil, it's not there. So see, whenever you're remembering, like I told you in biochemistry last class, any particular material or any particular thing in your body, try to remember it as why is it present. We could have done with the prevertebral fascia, right? We need not have another fascia. The reason why we are having another fascia is, it's going to cover it up. It's going to make it smooth. The holes or the spaces that you can see between the two vertebrae, that is what it's going to cover. You're going to have one single column. So that's why you need another fascia, that's the alar fascia. Okay, so try and remember it that way. Okay, so the next one you go through is, this is the carotid sheath. Can everyone see? Like we spoke, where it goes up to the skull and down to the heart, right? Okay. Now we are talking of superficial pterygoid space. Now see, these are pretty common. You've gone through it 100 times in your oral surgery while giving injections, right? When you're giving your inferior alveolar nerve, your lingual nerve, so you know. Basically the boundaries is something you have to by heart. What I'm trying to tell is, if you remember the picture or the diagram and you remember some landmarks, it's easier for you in the exam rather than by hearting the whole thing. Okay, now when you talk of parapharyngeal space, right? Parapharynx, so it's around the pharynx. It's parapharyngeal, adjacent to the pharynx. Here you have the superior constrictor. Here you have the superior constrictor muscle, right? Can you see this? Yeah. So basically you know how the superior constrictor muscle is. You know the anatomy, right? It's basically like a covering. You have this huge V-shaped, or you know, something like this, which is the superior constrictor, then the middle constrictor, then the inferior constrictor, behind which you will have your pharynx, right? So this becomes the, behind this is going to be the parapharyngeal space. Okay? So moving on to the next picture, see here. Same thing, you are having your parapharyngeal space, you are having your superior constrictor muscle, peritonsillar space. Now I have a question for you. What is the infection of the peritonsillar space known as? Quinsy. Yes, it is Quinsy. Okay. So now you know, peritonsillar, around your tonsil. Why would you get peritonsillar infection or peritonsillar abscess? The reason being, you will have tonsillitis, right? Everything is, see, every visceral organ is somehow covered in some sort of fascia, right? So whenever you have an edema or whenever you have the abscess formation, it's going to swell in size and it's going to block. So that's why you have something known as the hot potato voice seen in Quinsy. The reason being, tonsils are in very close proximity to your vocal cords, right? So if it's going to swell and block up that area, the patient is going to find it hard not only to swallow, not only to sometimes, you know, even breathe. He'll also have problem in talking. That's why it's called as hot potato voice, as if he has swallowed a hot potato. Okay, so that's about peritonsillar space infection or abscess and Quinsy. Okay. Okay. So you know the pterygomandibular space, right? The pterygomandibular raphe in the space, that is something that you've gone over and over again. Okay. Buccal space and masseter muscle and everything. Now let's go on to individual slide and individual diagram. Okay, this is the top part. You have the temporalis muscle. See, you can, this is the section taken like this from behind. Can you envision it? See, this is the skull, right? Okay, someone has cut the skull from behind into half. Jyoti, it's called hot potato voice. Okay? Hot potato voice. See, just imagine, you know where your tonsils are. Right? Right just behind your posterior part of your tongue, you have the tonsils. Right? So imagine if tonsils, yeah, it is hot potato voice. So when it swells up and you expect it to talk, it feels as if you have put something inside the back of your throat and you're trying to talk. Like sometimes when you swallow something hot and at the same time you try to talk, the way your voice comes out. Okay? Okay. So now see, this was what I was telling you. Cross section of the skull, right? Taken it in a sagittal direction. Yeah. So see, this is the mandible. This is how the mandible is going to look after the sectioning. This is the temporal fascia. Can you see this? See, temporalis muscle is here, and here you have the temporal fascia, which is going to attach to your zygomatic arch. See, this is zygomatic arch. Can you imagine the structures now? Yes. So now imagine you have a fascia right here, you have a temporalis muscle here, and you have a superficial temporal space. The spaces need not necessarily be empty. It will have something, it will have certain nerves, it will have certain arteries. Priyanji, you have to, because I can't show you videos. Okay, fine. Okay, now see the section. Okay, I'll try to explain it to you. This, can you see this? This is the skull, right? The top part. This is the mandible. Yes, Kirti, it is the concept behind your Gill's temporal approach. Okay. Now see, coming back to the picture, try and understand. You take your skull, okay? You have your frontal part and you have your occipital part. Getting it? Okay? In between the frontal and occipital part, give it a cut. Okay? So what do you get? Including your mandible, along with the whole thing. Take a huge saw and just cut it up in between. You have this, the frontal part, this is the occipital part. In between you are giving it a cut. Fine. So your mandible, and you watch, now you're going to take the front part of it, which is the frontal part, you've cut it, right? This part, turn it around and you're going to see it like this. So you're going to see, no, not exactly in lateral ceph. Lateral is this way, right? I'm not talking of this way. I'm telling, take your face, cut it like this, in between the skull. Okay? Okay. So now observe it. Now see, the posterior part is not there. You getting it? See, this was supposed to be filled with your occipital bone, right? This was supposed to end in a condylar process like this. Can you get it? But instead you've cut it. So when you cut it, your mandible is just going to look like one roughly a pear-shaped thing, right? You're going to see only a part of your middle cranial fossa, a part of your sphenoid bone, etc. because you've cut it into half. The occipital part, the actual middle cranial fossa, the posterior cranial fossa is all missing, right? So now when you talk of the muscle attachment, it comes in the side. You're observing it from behind. This is how the muscles are going to look like. The part of the temporal bone is still there on the skull. So you're going to have the temporalis muscle like this. You know the insertion of the temporalis muscle. It inserts in this part of the mandible. Remember? Few fibers, interior part, coronoid process, yes. So you got it. You have removed the actual coronoid neck and everything because you have cut it off. But you can see the attachment here. Right? Now, how will your zygomatic arch look like? It's going to look like a small circle. Is it not? When you cut it, it's going to look, the cross section is going to look like a small circle here. Can you see the circle here? Yeah. So what happens is, the fascia, which is going to be obviously outer to the muscle, is going to come like this and join your zygomatic arch. Okay? And from below here, okay, you're going to have your masseteric muscle. So the top part of the zygomatic arch is going to be attached to the temporal fascia, and the lower part of the zygomatic arch is going to be attached to the masseteric muscle, which is going to go right under the inferior border of the mandible. Are you getting it? Can you imagine it now? Anindya, you can imagine it, right? Okay. Okay, this will be the mandible. Okay, and you're going to have your lateral pterygoid muscle. That is just so much. Okay, forget about it. Now you got this particular thing straightened, right? This is your sphenoid bone, everything. Okay, now forget about this part. This part might actually confuse you. So what I'm trying to tell is, this is a potential space here. Right? This is a potential space here. This is a potential space here as well as here, in between the muscles and their attachments, etc. So got it? Now suppose you have, say, an infection here. when I say here, I'm not talking of this part of the mandible, I'm talking of go a little anteriorly. Like take a three-dimensional view, you're going to have teeth sockets in anteriorly, right? Here, inside like this. Right? So, suppose you have an infection there, perforates through this mandibular bone, comes off into this space. Where are the chances it might go? It can go here. Right? It can go up to your zygomatic arch through the buccal space, it can go up to your temporal fascia. Right, got it? Suppose it perforates from your lingual side. Where can it go? It can go to the pterygomandibular space. Okay? If it somehow perforates your muscle, it can go through infratemporal space. Right? So that's how it can spread through various spaces. It can't be confined. You can't say it's confined. Okay? So I'll go to the next slide now. So now in anatomically you know what it is, right? The zygomatic arch. Top part attached to the temporal fascia, lower part attached to the masseteric muscle, which goes and ultimately ends in the lower border of the mandible. Okay, so the next slide. How do you classify spaces? This is not essential. Just remember what do you mean by primary spaces, which are going to be primarily involved. When we are talking of primary spaces, we are talking of odontogenic infection point of view. So all these spaces, the canine, the buccal, the infratemporal, all this come under vicinity of some or the other tooth, whether it is anteriors or posteriors. So they all, actually from the net itself and some from the textbook also, Jyoti, I mean it's not from a particular site. I just go to Google and I go in for images. You can check it out. You have many images like that. Okay? Okay. So from, so you know the primary spaces, right? Submental, buccal, submandibular, etc. Indirect involvement, that is, if they manage to go through the primary spaces and then continue, you don't treat the infection continues to spread, it will go off to the secondary spaces, which are not directly involved with the teeth, which are not in direct or immediate contact with the teeth. See, mesenteric, pterygomandibular, parotid, superficial, deep temporal, etc. Now when I was talking of mediastinum, if you guys have time, go type mediastinum and go to wiki. Okay, in Wikipedia they've given a picture. It's a normal picture, but you will get the whole point of the mediastinum being a bag-like structure, having your heart wedged between your two pleural cavities. Okay, after the class you can do that. Okay, so moving on. Clinical significance, right? Face, buccal, canine, masticatory and parotid. These are all. Can you please show previous slide for a minute? Okay, fine. Here. See, basically Aruna, you don't have to by heart these. Okay, whichever slides I feel are not important, I'll skip through. Okay, because it's not going to, you don't have to by heart this. It's just common sense. You know, mesenteric is nothing to do with your tooth. Okay? Okay, primary spaces. See, this is easy. The immediate spaces, the submental, the buccal, all the basic things where you give your injections, right? Okay, so moving on. Suprahyoid. Okay, face, what matters to us clinically? Buccal, canine, masticatory, that's the posterior part, and the parotid. These are the spaces that we actually know, right? Suprahyoid, anything above the hyoid bone. Sublingual, submandibular, lateral pharyngeal and peritonsillar. So can you imagine when I say lateral pharyngeal, pharynx, lateral to the pharynx, and peritonsillar at the back of your tongue, right? Where the root of the tongue. Got it? That's suprahyoid. Anything above the hyoid bone. Infrahyoid is pretrachea. Once you cross the hyoid bone, you start off with the trachea. Pretracheal. Spaces of the neck. Now see, retropharyngeal and carotid sheath and all, they become spaces of the neck. They come in contact with your cervical vertebrae. So they become spaces of the neck. Right? Okay. Now this is from our text only. Canine space, boundaries. Now you need not remember each and everything like I said, but you need to use your common sense when a question comes up. Okay? See, superiorly what can you have? I'll show you the diagram. Right? Then we'll come back to this slide. See here. Can you see this red spot out here? This is how the canine infection or canine space infection can spread. So what all muscles do you have around it? You have the orbicularis oris. You have the levator labii superioris. See, the words itself suggest the upper lip superioris, which elevates your upper lip. Right? Zygomaticus major, which comes right adjacent to your levator labii superioris. Then you have this levator labii superioris aliquenasi. That is your ala of the nose. Okay, muscle going from ala of the nose to your lip. Okay? Then you have your zygomaticus minor. You have your levator anguli oris, buccinator. See, basically what happens is when you talk of space and its boundaries, you're going to have many muscles which are going to be present superiorly, inferiorly, roof and floor and everything. It's quite impossible for you to remember or by heart everything. So just remember the diagram, and depending on what question they ask, suppose this is superiorly, try to imagine the diagram, try to imagine what muscle which they've given in the option can possibly form the roof. Right, now suppose I say your levator labii aliquenasi is going to form the floor of the canine space. Is it possible? No, right? It's not going to be. The word itself suggests that it is going to be somewhere around the roof. It's going to form the roof. It can not possibly form the floor. Right? So that way you can rule out certain things. So here you go. Now one more thing about canine space infection is, if you observe carefully the position of this red part of the face that is, that suggests your canine space infection is, now suppose you're giving a very commonly given injection, that is what? Infraorbital injection, right? Infraorbital nerve block. When you give infraorbital nerve block, what happens? Your needle might actually cause transfer of an infection or cellulitis which is present here directly up to here. You getting it? Suppose a person has come, yeah, Kirti, it's the eye. It's going to directly affect your eye. Suppose a person comes to you with an infection, canine space infection, but it is still not that obvious. You're going to give him an injection for, or a block for extracting your canine. Without knowing, you're going to go through all this area right up to your foramen, right? So what are you going to do? You're going to carry, with the help of your needle, the infection right up to this foramen, and from there it's obviously going to spread out and affect your eye. It's going to worsen the condition. Yeah, famous myth that extraction harms the eye comes from this, basically. Okay? Okay. So that's one thing about the canine space infection. I'll give you 2 minutes to go through this. Okay? Superiorly, quadratus labii superioris. Inferiorly, orbicularis oris. Okay? Deep is going to be the anguli oris and anterior surface of maxilla, etc. Medially, it's going to be the aliquenasi thing. And main thing is, what are its contents? It's going to have your angular artery and vein, and the important thing is infraorbital nerve. Okay? Okay. So we'll move on to the next slide. Okay. Now we go to the buccal space. Right? one sec. Yeah, here you go. This is the buccal space we are talking about. So this is, now you know this is the maxilla, right? This is the mandible. Now buccal space is one thing where you can have infection from both maxilla as well as mandible. Any direction it's going to go, it's going to ultimately affect your buccal space. Okay, that's like, you can say that it's like a connecting space for everything. In the mouth, it's going to be the connecting space. See here, it's going to connect your maxi, mandi, palatal, everything. Okay, so buccinator is there. See, this is how it's going to look like if you have an abscess or a buccal space infection. This is how it's going to look like. It's going to come right out of the tooth, right? It's going to perforate your buccinator muscle, and it's going to go between the skin and this fascia, buccinator fascia, which you have. Okay, so it's going to swell up on your cheek. So you can imagine that. So we'll go back to seeing the boundaries and the contents, etc. Okay. So anteriorly, it's going to have posterior border of zygomatic bone above and depressor anguli oris below. So imagine the zygomatic bone, the posterior border of the zygote. See, here it comes, right? Buccal starts from here, this part, the cheek part, not the front part. So posterior border of zygomatic bone above, the infratemporal fossa, that area, and the depressor anguli oris below. Are you getting it? The depressor anguli oris and this posterior part of your zygomatic bone, that's anterior. Posteriorly, anterior border of the masseter. So it's limited. Where your buccinator muscle ends, your buccal space ends. Masseter becomes a masseteric space. So that's easy, right? Superiorly, it's going to be the zygomatic arch. Inferiorly, inferior border of the mandible, because it's going to go through and through. Laterally, of course, is the skin and the subcutaneous tissue, skin of the cheek. Okay? So the next one, what are the contents? So you know, what are the contents? Parotid duct, obviously. It pierces your buccinator muscle. So it has to go through the space. So parotid duct, anterior facial artery and vein, it comes like this, right? Anterior facial artery and vein, transverse facial artery, buccal cheek fat pad, etc. These are the things that are present. Got it? So I'll move on with the next thing. Yeah, so see this, how it looks. Skin is here, subcutaneous tissue, skin, right? It's going right up to your, here, it can go way below your inferior border of the mandible. And right up to here, where the zygomatic bone is going to end. Okay? So we move on to the next slide. Okay. Now see, this is another picture. Can you see? This is slightly contained. So can you make out how it looks? This is the muscle, right? This black thing is the muscle. This is the skin and the subcutaneous tissue, and in between you're having this. It's going right from maxilla up to the inferior border. It can spread, but they are showing it right from the root right now. So as I said, it's contained. Potential space involves upper jaw and lower jaw. Okay. Now we go to the temporal space. Now I want you to imagine the diagram that I had shown you before, which you guys found it a little difficult to imagine. Remember the temporal fascia, the temporal muscle attached to the zygomatic bone. Remembering it, right? Right. So now it becomes easy. Superficial temporal space is going to lie between the temporal fascia and the temporalis muscle. Can you imagine the space now? Yes. Deep temporal space is going to lie between the temporalis muscle and the skull. That is hardly a space actually. See, you remember the temporalis muscle, right? It's going to go like it's going to go actually attached to your skull, but it also has some amount of space, a potential space. Always remember, whether you talk of a periosteum, the layer covering your bone, whether you talk of your muscle attached to your bone, there, whenever you're having cellulitis kind of a problem or an edema kind of a problem, it is very easy for this edema fluid or for the abscess or for the cellulite to separate the muscle or the periosteum from the bone. So always, don't think that, just because you have a muscle attached to the bone or maybe muscle attached to the skull, there's no potential space in between. They can be easily reflected. Like you reflect using a periosteal elevator, right? Even the edema fluid or the abscess or the pus can easily reflect it. So always you're talking of deep and superficial. Superficial will be between the visceral layers. See, it's between the fascia and the muscle. But the deep part is right next to the bone, muscle and the bone. Got it? See here, can you see this? It's just a CT scan. You can't make out, but I'm just telling you how it looks. See, this is the normal side and this is how it looks. Okay? Okay. The parotid space. The parotid space is very easy. Space is formed by splitting. You know that parotid has a fascia, right? Parotid fascia, everyone knows it. So space is formed by splitting the superficial layer of the deep cervical fascia surrounding the parotid gland and lies posterior to the masticator space. Just okay, we don't have a slide for it. Okay, just let me see. One sec. Parotid. Okay. Can you see the parotid salivary gland in this? You can, right? This is the parotid space. So let's imagine, you know how the buccinator space was. It ended right where your masseter muscle started. Now we're going beyond the masseter muscle. Can you see this? This is the masseter muscle. The whole thing is the masseter muscle. We're going beyond it. We are going beyond it next to the parotid gland and this. That is your mandible and your parotid gland, right? So this will form a potential space known as parotid space. Okay? Okay, so just imagine that and we go to the theory. Space is formed by splitting the superficial layer of the deep cervical fascia. So just imagine you have your parotid gland, okay? It has the deep cervical fascia covering it, forming the parotid fascia. You split the superficial layer and you provide a potential space. Got it? And inferiorly you have a ligament which is going to separate your parotid space from the mandibular space. So whenever infection has to spread, all it has to do is damage the ligament or go through the ligament for it to reach the mandibular space from the parotid space. Okay? Okay, so we'll move on to the next slide. Now we go to the submental space. That's very easy, right here, right near your premolar region. Now when you talk of submental space, suddenly think of it that it's right near the midline, right? So what happens is you don't really have any structures, soft tissue structures in the skull, especially in the mandible, which is going to form a barrier for your spread. So very easy for the submental space infection to spread from one side to the other side. Got it? It's very easy. So submental space, lower border of the mandible, is going to be laterally the lower border of the mandible, anterior belly of digastric. Okay, superiorly it's going to be the mylohyoid muscle, and inferiorly it's the suprahyoid portion. So we are talking of this space. We are not talking of submental foramen, mental foramen or anything. We are talking of the potential space. So below the space is out here, directly below it's going to be the hyoid bone, right? Superiorly it's going to, laterally it's going to be the lower border of the mandible, jutting out, anterior belly of digastric, and superiorly it's going to be the mylohyoid muscle which forms the floor of the mouth. Got it? So roughly you know how the space looks. See, this is the same thing. Likely source of infection obviously is going to be the mandibular anterior teeth. See, this is how it's going to look. Can you see this submental space? This is the muscle we are talking of, the mylohyoid muscle which is going to form the roof. Okay? This mandible is going to go all the way like this, right? So it's going to form the lateral border. So you're getting it? And it can easily spread. See here, it can easily spread because there is nothing that is obstructing the midline. So from one place to another place. And because it can spread across the midline, it can also go backward. And backward you have your submandibular space, sublingual space. So that's how the infection goes on spreading. Backward, forward, upward, downward, anyhow it can spread. Okay. Now the sublingual space. So sublingual, the word itself suggests, right? Superiorly it has to be covered by the floor of the mouth. Inferiorly it's going to be the mylohyoid muscle because it's obviously above the submandibular thing, right? And it's also going to be above your submental thing. Can you get it? It's more superficial, or when you say it's more superiorly placed as compared to your submental. It's right here, just below the tongue. Okay? So medially all the muscles, see this is, sublingual is one thing where it is surrounded by the muscles, in mylohyoid muscle. Okay, hyoglossus muscle, medially, genioglossus, hyoglossus, geniohyoid, everything is medially. Posteriorly it's going to be the hyoid bone. See, because posteriorly technically you don't have anything else to, even though hyoid bone is going to be way below, you're going to call it posteriorly. Are you getting it? Okay. Okay, so got it, right? It's more superficial, it's just below your tongue. Way below you're going is submental. See here. This is the tongue and this is immediately just below it you're going to have your sublingual infection, raising the floor of the mouth. This is your tooth, right? This comes the mylohyoid muscle here which forms the floor in this case. Got it? Okay. Submandibular space. Okay? Now, first let's see the diagram, then we go to the theory. Submandibular space obviously is going to be way below your sublingual. Agreed, right? It's going to be below your mylohyoid muscle. Can you see this muscle here going like this, forming the floor of the mouth? You can see it, right? So below this is what you're going to have your submandibular gland, and there you're going to have your submandibular infection space. If you talked about this muscle, above this muscle, it would be your sublingual. Yeah, correct. So you got it. So you know the boundaries more or less. See, this will be a sublingual space. This will be a submandibular space. Both are separated by this mylohyoid muscle which is forming like a carpet, like a floor. Okay? So going back to the diaphragm of the oral cavity. Yes, Tawani, that's the right one. It's called the diaphragm of the oral cavity. Boundaries are superiorly inferior medial surface of the mandible, attachment of mylohyoid, anterior and posterior belly of digastric. So this is basically going way below, right? Something to do with the hyoid, the digastric. That's going to be the floor. Superiorly, what was the floor for the sublingual space becomes the roof for the submandibular space. Are you getting it? Yes. Okay, so got it, right? Inferiorly it becomes the digastric. The laterally, again, skin, superficial, fascia, platysma, etc. We have left the inferior border of mandible behind. It's way below it. So we can't use the inferior border of mandible in this. Medially again, it's going to be a hyoglossus, superior constrictor, because we're going below your genohyoid, etc. We are going to go with superior constrictor, the muscle which is still further below. Okay? Then you have your contents. Okay, it's going to be the submandibular gland, obviously, facial artery, and some lymph nodes. So the main thing you're going to know is the submandibular gland. Okay, so the next topic, we are done with this. So can you see the thing, the submandibular gland, the mylohyoid muscle, the tooth, and the infection going right below. And here is your platysma muscle. So it's like, if you look at it, it's like sandwiched between the platysma here and this mylohyoid here. Right? You can understand it now? Okay. So move on to the next slide. This is the same thing again. How can it spread? Genohyoid muscle, this is the mylohyoid. So this is going to be a sublingual, this is going to be a submandibular. Okay, now the submesenteric space. That is your masseter muscle. So anteriorly, obviously it will start where your masseter muscle is going to start. The word itself suggests anterior border of masseter muscle and buccinata. Posteriorly, it's going to limit itself to the parotid gland, because from parotid gland, parotid fascia itself is going to form its own space, right? So posteriorly, it's going to limit itself to the parotid gland and posterior part of the masseter. So in short, the mesenteric space is going to extend to the width of your masseter muscle. Once the masseter muscle stops at the entry of your parotid gland, the space also stops. Okay? Yeah, so inferiorly, attachment of the masseter to the lower border of the mandible, that's where your masseter is actually attached, the lower border of the mandible. Medially, what do you want to have? You want to have your ramus. Right? So medially, this is going to be the bone, the ramus. Laterally, again the muscle. So submesenteric space is basically enclosed in your masseter muscle only. The extent of the masseter muscle is going to determine the extent of your submesenteric space. Got it? This is the easiest space, I guess. Okay. Now the pterygomandibular space. This is something that you guys know it, because basically you have to learn it by heart. Laterally, the medial surface of the ramus of the mandible. Medially, the lateral surface of the medial pterygoid muscle. So can you remember it like this? It's opposite. Laterally, you're going to have the medial surface of the ramus of the mandible, the bone, okay? And medially, you're going to have the lateral surface of a muscle, the medial pterygoid. Priyanshu, see, imagine if you're having infection from the mandibular first molar, it's going to go into your buccal space. Agreed? So from the buccal space, the next space is what? A mesenteric space. Right? So that's what I'm trying to tell you. All spaces are interconnected. So don't think of it that, just the proximity of the tooth to one particular space limits the infection. Just because you have a canine space infection, it doesn't mean that it cannot spread to your buccal space, it cannot spread to your submandibular space. It can spread to anywhere it wants, because all the spaces are interconnected. Once a particular space gets over, the next thing is another space. Right? You're going to have your buccal space. Next to it is your mesenteric, submesenteric space. Next to it is your parotid fascia. Right? So it goes on. Okay. What was the question? Okay, I got the infection part. Trismus is due to infection in the mesenteric space. Yes, trismus can be infection in the mesenteric space. Trismus can be infection in your temporal face. Right? You're having one right now, Soumya. What happened? You got your impaction done? That's too bad. I guess pericoronitis. Okay, so why don't you get it extracted? That's the only way out. Okay, fine. So posterior, so you'll be better able to understand where you can have trismus and where you cannot. Okay? Okay. So coming back to this, so you know the pterygomandibular space, right? Lateral, medial, posterior, anterior. Anteriorly it's the raphe. That's what you're going to pierce when you're giving your inferior alveolar nerve block. Alright? Okay. So moving on to the next slide. So this is Quinsy. Remember? Peritonsillar abscess. Can you envision where this outer part, just try to imagine the patient's inner mesenteric space. Most common tooth is mandibular third molar. No? Actually more than mandibular third molar, I think it's the pterygomandibular space for your mandibular third molar, Kirti. Okay? Just remember it as where you're going to give an injection. It's going to be there, right? It's going to be just the proximity of your pterygomandibular space is more, because see, most of the time when you're talking of pericoronitis, the tooth is embedded in the bone, right in the ramus. So that is very, very close to the place where you're going to give your injection. That is the pterygomandibular space, more than the submesenteric space. Okay? Okay. So this is about Quinsy. This is how an untreated patient is going to have the pus coming out from the external surface. Okay, Kirti, just imagine your mandible. Remember how your third molar placement is. It's going to be way up in the ramus, right? When you're talking of pericoronitis, most of the times it's embedded, it's impacted. No, Tawani, complication of pericoronitis is not Quinsy. See, it can, when you say can cause, pericoronitis can ultimately even go up to meningitis. The can part, see, whenever, even in MCQs, there are certain words you have to be very careful of. When they say possible, is it possible? Or when they say can it? Or most probably. These are all broad terms. Right? You have to go in for even the vaguest of the answers, because it's probable. It can happen. The worst of the complications can even lead to meningitis. Right? So Quinsy is peritonsillar abscess. So if the patient has a pericoronial infection which is not at all treated, and it going through the various spaces like pterygomandibular space, from there goes to your peritonsillar space and infects your tonsil, you can have Quinsy. Okay, you can't rule out that option. Okay? Okay. So Kirti, did you understand what I'm telling? Just imagine your third molar, okay, embedded inside the ramus, and just imagine how do you palpate when giving your pterygomandibular raphe region. How do you palpate when you're giving your inferior alveolar nerve block? You go, right, you go to the anterior border of the mandible, the ramus, etc. That's how you go, right? So that is where your tooth is actually present. So immediately next to it is what you're going to have is your pterygomandibular space. Of course, if it comes out through a buccal plate, suppose your pus perforates, the infection manages to perforate your buccal plate of the ramus. comes out, yes, it is going to go to your submasseteric space. It's possible. But when you talk of most common case scenario, immediately what is affected is your pterygomandibular space. Got it? Okay. So we'll move on to the next slide. Here. Okay. So lateral pharyngeal space. Imagine your pharynx. Okay, imagine the pharynx being covered by a superior constrictor, middle constrictor, inferior constrictor, and imagine the lateral portion of the pharynx. That forms your lateral pharyngeal space, both the sides like this. So cone-shaped space, pharyngeal space is nothing but a cone-shaped space with the base at the skull. Okay, apex is at the greater corner of the hyoid bone. It becomes triangular. So just imagine you're covering up the pharynx with these three constrictor muscles, giving it a cone-shaped appearance, right? Superior constrictor is wider, middle constrictor is slightly less wider, inferior constrictor is less wider than the middle constrictor. If you've seen the diagram in your Chaurasia, that's how it looks. It goes like this, V-shaped. So, when you talk of the lateral pharyngeal spaces, you're going to have a cone-shaped space. Okay, the base is going to be the skull base near your superior constrictor, right? The skull. Okay, and the apex is going to go right up to your greater corner of the hyoid bone. Are you getting it? Okay, so you're going to have your anterior and posterior compartments in this. Okay, now let's see this. Retropharyngeal space. What is retropharyngeal space? You go beyond the constrictor muscles, you go beyond the pharynx. Behind the pharynx, you're going to have another space. Yeah, so it's retro. So extension from, so what happens is, see, this is again an important point. It's an extension from your lateral pharyngeal spaces. That means your lateral pharyngeal spaces are connected with your retropharyngeal spaces. They are not separate. They are ultimately connected. So if you have an infection in the lateral pharyngeal, it can very well go up to your retropharyngeal space. Got it? Again, even because it's retropharyngeal, it is going to extend to the base of the skull to the upper mediastinum. It's going to go slightly lower. Your lateral just ended at the hyoid bone. Because this is behind the pharynx, it's going to go way below to your mediastinum, the upper mediastinum. Got it? You know what the mediastinum is, right? Starts from your sternum, manubrium sternum, and forms a sac. So upper mediastinum, up to there it's going to go. Got it? Lies behind your esophagus and the pharynx. Okay. So just imagine that this is the same thing we saw. Okay, now it becomes, now you can actually imagine how each and everything can happen. Each and every space infection. Okay? Okay. Anatomical consideration in dentoalveolar infection. So, this is obvious. So, let's go through it. Whatever we have done, this is how it's going to come down, ultimately. Maxillary incisors and canine. Where is it going to go? Obviously, the buccal vestibule. Are you getting it? Okay. Maxillary bicuspids, the premolars. Remember what happened in the premolar, the canine, even actually bring down the canine also in this. Canine can be here, canine can be here also. Because see, cellulitis of the eyelid means you're talking of the infraorbital area also. Canine space, Kirtijan. Exactly. Remember, when you're talking of canine space infection, it was that you can have an infection of the canine as well as the first premolar for it to cause that kind of infection. Remember? Yeah. So the mistake here is canine should also be included in this. Okay? May cause cellulitis of the eyelid, may extend into the buccal space. So we're still talking of the buccal space. We have not finished with the buccinata. We have not moved on to the masseter. Maxillary molars also, buccal vestibule only, right? Infratemporal space. Now because this is maxilla, we go up to the temporal part. Infratemporal space. Okay? That was about the maxilla. Now we come below. Mandible. Mandibular incisor and canine. In the labial sulcus, if you talk, again you will have a buccal space infection. Labial sulcus. Superficial to the mentalis origin and submental if inferior to the mentalis origin. Got it? Moment it goes to the labial sulcus, it has every chance of going into the buccal vestibule. But if it goes below the mentalis muscle, perforates the mentalis muscle and goes, it's immediately going to enter your submental space. Got it? Yeah, Priyanshu, submental space. Now we go to the mandibular, molar and premolar. Right? Like when you talk of maxilla, we go to the upper part of the skull, we talk of the infratemporal, the temporal space, etc. Now the lower part is the mandible. Mandible is going to go, it has no way to go in the front, it's going to go backward. Right? That's the only way it can go. It can go parapharyngeal, masticatory spaces, that is the submesenteric comes under it, pterygomandibular space, that's how it can move. So basically when you talk of space infection, what is the possibility that it moves in a direction is, that's how it can go. Maxi, it has the potential to go upward, near your eye, infratemporal, the temporal, etc. Mandi, least resistant, exactly, it will go through the path of least resistance. Okay, so mandible, the only way it can move is backwards. So if you see generally, okay, mandible poses more threat for your danger spaces and more of, Ludwig's angina, strangulation, asphyxiation, all that possible in mandibular. Priyanshu, maxillary infection is going to go to your infratemporal space. Remember the palpitation while giving your PSA? You guys remember it, right? Behind, where your zygomatic bone, buttress, etc. You remember that? Lateral incisor can very well go into your buccal space, because see, even though we call it as the buccal space, it covers up till entire mouth, right from the midline. You don't have something known as the mental space like in Mandy here. Right? So, moment it enters, it's going to enter the buccal space, and if possible, it can even go to your infraorbital space, that is up to your eyelid. Got it? Yeah. Canine space. It can go up to the canine space. Understood. In Mandy, we have bifurcation, thankfully. We have mental, submental, submandibular, etc. Maxi, we don't exactly have that kind. It's just the buccal space that you have through and through. You can say labial sulcus, but ultimately that is going to lead to your buccal space infection only. Palatal also. So if it perforates, now the reason why I didn't say palatal is, palatal bone is slightly thicker when you talk of the plates. So less chances of it to perforate the palatal bone unless and until the root is bent palatally. Okay, then it can go right up to the palatal swelling, and from palatal where else can it go? Tonsillar space, retropharyngeal space, parapharyngeal spaces, again backward. That is the way firm attachment, that's what Soumya, no matter how firmly you think it's attached to the periosteum, remember I told you, whether it's a muscle attachment, whether it's a periosteal attachment, it is possible for the infection, for the cellulitis to break the attachment. Got it? Even though you say that it is firmly attached, there is no much muscle structures present in the palate, it still can cause a potential space infection. And ultimately, you can say that that is the pathway for the maxilla to move its infection backward. See, mandible can move its infection only backward. Right after submental and submandibular, there is no other way for it but to move retromandibular, parapharyngeal, pterygomandibular, that kind. For maxi, it has potential to move anteriorly, the eye, the buccal space, the canine space, and one way of it to move backward is through palatal area. From palatal space, it can go up to your pharynx, retropharyngeal, and so on. Got it? So you can imagine, right? Okay. See here, if you observe the arrow marks, they show you the potential directions an infection can go from maxi. See, it can go upward, right? Infratemporal. It can go here, palatally. There is a sinus, maxillary sinus also. It can go palatally. It can go buccally. And it can go even, it can just come out. See, sometimes if the patient is lucky, what's going to happen is maximum it's going to perforate your labial cortical plate and form a sinus tract and drain into the labial sulcus without going into any space technically. Specifically speaking, which is a better choice for buccal or palatal? Or I didn't get your question. See, because if they won't basically ask you a question saying that where will your say lateral incisor spread. If it does, you can go for both the options because it is going for lateral incisor. I'm talking of lateral incisor. You can go for both the options because it is different in different patients. For some patients, the labial cortex might be very thin. Assume that a patient is very old. Palatal abscesses are common, I agree, but I'm talking of the facial infection. We're not talking of an abscess that you see in your IOP radiographs. Answer is given as palatal, Kirti. Are you sure? Okay, so this might be considering the fact that the root, okay, the root of the lateral incisor is going to be tilted palatally. Okay? But if you have an option of labial sulcus as well as palatal abscess, you can go in for, see, when you talk of palatal abscess, you're not talking of an infection which is, see, palatal abscess can be the one which you do for RCT, right? You take an IOP radiograph because the tooth is tilted palatally. The position of the abscess you're going to say is palatal abscess. I am talking of facial planes, potential space infection. Are you guys getting me? Coming back to the fact we had in biochemistry, if you guys can remember, we had this particular question, right? Fat absorption and fat digestion. Okay? You guys told me it is jejunum. Okay. I found out, okay, that it's two different things. Remember, digestion and absorption are two different things. Absorption is what that takes place in your jejunum and ileum. Digestion, fat digestion occurs in the duodenum. Again, the reason being, all your bile duct, your pancreatic duct is going to open in the duodenum. Even though it's a very short part of the small intestine, digestion, breakdown is going to occur in the duodenum. The absorption part, where the microvilli are prominent, all that part is going to occur in your ileum and your jejunum. Got it? So that's what. The words palatal abscess, these people are thinking of the endodontic term here. Because your tooth is tilted, because the tooth is generally palatally facing, all that. I'm talking of the facial plane of the infection. Potential space infection. Okay? So observe the question, see what they're trying to ask, and then answer. It can be both of the above. It can be the labial sulcus and palatal bone, or it can be the palatal abscess. Okay? Okay, so we'll move on to the next slide. Lower third molar, this is what you guys were asking, right? See, where all it can go. Lateral pharyngeal space. Can you see this? Buccal space. Okay? Sublingual space. Submandibular space. See, these are all the possibilities. Okay? When seen in horizontal section, infection may track laterally into the buccal space, posteriorly either side of the mandible into the masticatory space. They have just generalized it saying masticatory space. Okay? Further medially into the lateral pharyngeal space or lingually into the sublingual space. Okay. So on to the next. So these are the incisions basically that you have to give in order to drain, extraoral drainage. The photo is a little faded, okay, but just observe the positions. Temporal, superficial and deep temporal, submasseteric and all, you have to do it out here. Even for submasseteric you have to do it out here. This is the safest part. Okay, submandibular, just below the inferior border of the mandible. Submandibular, sublingual, submental, slightly in the front. Again below the inferior border. Okay, lateral pharyngeal and all, you're gonna do it out here, below this, near, you can say at the level of hyoid bone. Okay, this is not important for you guys, this is just basically information. Okay, so we know what is Ludwig's angina, everyone? Okay, so we'll just go through this. Complication of an orofacial infection related to the lower jaw. Basically we are talking about the floor of the mouth when you talk of Ludwig's angina. Break, okay, and India, you want a break? We'll take around 5 minutes break, everyone? Okay, 2 minutes break, fine with me. Okay? Guys, you can hear me? Okay. So we'll start? Okay. Now we'll come back to this. Okay. So Ludwig's angina, you know basically what it is. Okay. Okay. Etiology, you can have an odontogenic infection, pericoronal abscess, dentoalveolar abscess, periodontal abscess, so anything to do with the tooth. Okay? And osteomyelitis also. Okay. So what are the basic features you need to remember? Just remember these words. It's firm and hard, brawny swelling, board-like firmness the swelling has. Edema is there, pain is there, obviously there is going to be limited opening of the mouth. You're going to have dysphagia, and systemically you can have toxemia, septicemia, leukocytosis, and ultimately in severe cases you will have brawny swelling. Is a huge, brownish color, like usually, bodybuilders have bronze, they say, right? The muscle popping out. Yeah, so it's going to be something like that. When you touch it, it's going to be that hard and firm like a muscle. Got it? Okay. So what is the basic cause? The basic cause is it's a mixed infection, Ludwig's angina. Streptococci being the main reason for acting on the hyaluronic acid. Anaerobic infections or anaerobic bacteria are also there. They are primarily responsible for Ludwig's angina. An infection mainly spreads from mandibular third molar, whose apices are closely related to several facial spaces. So remember, Soumya, your mandibular third molar, like I showed you in the diagram, is related to several facial spaces. It's not limited. You cannot say that it just gets limited to submandibular or pterygomandibular or retropharyngeal. It is related to many facial spaces. Okay? See, this is one more thing. Even though they are normally adherent, muscles and other structures are normally adherent, they can be spread apart by inflammatory exudate. Okay? Okay. So spaces created in this way are almost avascular and inflammatory exudate carries bacteria widely through them. Okay, so this is basically boring, I understand. So let's move on. Okay? Yeah, Prasad, I know it's boring. You guys are more interested in the bomb blast, I understand, but we'll just move on. Okay? Finish this off. See, this is the base. Can you see this? This is the extent of the swelling the patient is having. No problem. Okay? I know it's boring. You've been hearing this from a long time. Okay? So see, this is how it looks. This was supposed to be the normal neckline, but see how it is spread, and see how your hyoid bone is compressing against the trachea, the structures behind it. Can you see this? Yeah, that's how you will have dysphagia, you will have problem in breathing, swallowing, etc. Okay? So the treatment plan, you know, early diagnosis, maintain a patent airway, all this surgical drainage, etc., etc. Okay? This is done. Now before we go, one question about Ludwig's angina. What is the preferred surgical treatment? Is it cricothyroidotomy or is it nasoendotracheal intubation? No. See, cricothyroidotomy is always, remember it as an emergency procedure only. Yeah, in India it is nasoendotracheal intubation. We prefer that. See, orally you can't put it basically because the tongue is up and there is a swelling in the floor of the mouth. So, cricothyroidotomy is done only and only when it's a highly emergency case. Patient is not able to breathe and you know he's choking and you need to relieve it. That's the only time you do it. Otherwise, the best thing is nasoendotracheal intubation through the nose. Got it? Okay, so we go to preprosthetic surgery. Okay? Now, in this, basically, you don't have to learn how the surgeries are. No one's going to write a 5 mark, 10 mark paper in this. Okay? What we are going to do is, we are going to remember the names, okay? And what exactly it is, in short. Okay, we're going to go through it very short and I want you to remember what the name stands for, who discovered it or who did it and what it actually does. So we'll move on. Okay, so you know what is alveoloplasty. Everyone knows it. You always do it after tooth extraction. You remove the bony spicules, you smoothen it. You basically prepare the area for receiving a prosthesis. Got it? Okay. See, now you have alveoloplasties which are of different types. We go through it. Simple. What do you do simple? You place an incision here. This is your alveolar bone. Okay, this is the mucosa covering your alveolar bone. You place an incision at the crest. Okay, remove the flap. Can you see this bone? It's jutting out here, right? It's supposed to be smooth. It's supposed to be looking like this. So, what do? You reflect this, you smoothen it, you either use a bone rounger, you use a burr, or you can use a bone file, anything depending upon the size, okay? And you smoothen it out, trim the bone and suture it back. Simple. It's simply done. Understood? Okay. So, the next one, a single tooth. You have a single tooth and you have this excess bony spicule on either side, jutting out. So, see, from occlusal level, this is how it's going to look. Can you see this? Wedge shaped. Okay? So, what you do is, you place an incision here. a wedge-shaped incision, and this excess bone, can you see this? This tooth is already removed. This is the excess bone you can find here. You remove it. Same thing, either a bone rounger or a bone file or a round burr. Anything, and suture it. Okay? So the next one is the radical. That means you're removing a chunk of the bone. That's why it's called radical. See here, incision is placed here as usual, the tooth is still there, and you have to remove this much part of the bone. That's why it's radical. Complete labial plate itself is removed in case of extreme prominent undercut. You can't do anything about it. The undercut is very, very prominent. What do? You remove the plate. See, this is how you do it. You've removed this much portion of the labial bone. And you've removed the tooth also. So this is how it's going to look. Okay, that's the radical part. You're removing a piece of a cortical plate. Okay? Okay. Interradicular or interseptal. The word itself suggests the interdental bone. That's what they are trying to talk about. Same thing, you do an incision, remove the tooth. There's an interradicular bone. Imagine this to be the interradicular bone. Okay? And remove it. Now, in this particular subject, I am talking of something known as a Dean's method. So what did Dean do? Suppose you do a multiple extraction. The patient is going in for a complete denture. Okay, you have extracted multiple teeth, there are interseptal bone, there is a bone socket present. Are you getting it? Now what Dean did was, he wanted to reduce the amount of cancellous bone present in between the two cortical plates. You have the labial and the lingual, and in between you have these sockets, the interdental bone, the cancellous bone, etc. So what he did was, he took a burr, or he took his bone rounger, crushed the interseptal bones. Okay? He took a vertical incision on the labial aspect. Okay, gave vertical incisions like this, reflected it, gave vertical incisions to the labial plate, canine to canine. Are you getting it? And push the labial plate behind, trying to join it with the palatal plate, so that he doesn't have anything in between. No cancellous part, no socket, no area in between. Okay? So that was done by Dean. Got it? So when you talk of Dean alveoloplasty or Dean's way of alveoloplasty, remember, he fractured the labial plate, canine to canine, pushed it in by removing the interceptal bone in between. He didn't want cancellous bone, he didn't want any spaces in between the two cortical plates. Got it? Now what Obwegasser did is, see, basically this guy Obwegasser, he modifies everything. He himself hasn't given any new contributions, but any person who has contributed, he has modified their functions or their surgeries. Now Dean thought of fracturing the labial plate and moving it behind. Obwegasser thought of fracturing both the palatal and the labial bone and moving it together. Both. The reason being, now the ideology behind Dean doing it is not only to remove the cancellous part and the space, it was also because if you have observed, an edentulous patient tends to have mandible resorbing at a very faster rate than the maxilla. So what ultimately happens is, the patient appears retrognathic with the maxilla being very prominent. Right? So the denture also looks awkward to the patient. So what happened was, Dean decided that he'll move the labial plate behind, so that the patient, when he becomes totally edentulous, the difference won't be so prominent, maxi to mandi. Maxi will appear a little straighter, not prognathic. Okay? Now, the idea behind Obwegasser doing a fracture of both palatal and labial plate was, in patients, suppose you have a patient who has been lifelong a class 2 patient. Class 2 as in, I'm talking of ortho. Right? He's got a severe maxillary prognathism. He can't do anything about it, he has not done anything about it, and ultimately he comes for multiple extraction and for a complete denture. Now this patient is going to have even worse facial profile after you give a complete denture. So just by pushing the labial plate behind is not going to help you. It's not going to bring that desired effect. So he pushes the palatal plate also. So he gets a much straighter maxilla. You got it? Okay. So that was about the alveoloplasty. Being one plate labial, obligus have both the plates. Okay? So this is the theory. Let's not go through the theory. It's the same thing what I told you. Okay? I'm pretty sure you guys will sleep if I make you read it. So I told it beforehand. So we'll do this. Now conservative alveoloplasty. Okay, Priyanshu? I know it's boring. So just put up with me for another 15-20 minutes. Okay? Conservative alveoloplasty is carried out of multiple teeth extraction. Dry topic, I know Soumya, I know. I'm trying to make it more colorful, but let's see. Okay? The alveolar bone is exposed by reflecting an adequate mucoperiosteal flap. Recontouring of the bone can be achieved by using rongeur. So this is basically very, very conservative. How much ever is needed. If you have a bony spicule, just attend to the spicule. If you are having prominence, just smoothen out the prominence. File it out. That's all. As conservative as possible. The word itself tells you that. Okay? Okay. So this you remember, right? This is the main two things because you have names in it. So try and remember that. Ridge preservation. Now this is a new ideology. I'll show you this. Can you see this? This is the extraction socket. Ordinarily, what do? Now, in multiple extraction is what we do is crushing and everything, right? Ordinarily, that's what we do. We allow the socket to heal, everything. Now, what they did was, they filled it up with some amount of autogenous bone graft and hydroxyapatite crystals inside the socket. Can you see this? It's filled. And then they gave a soft tissue covering. It could be that they can pull the labial mucosa and palatal mucosa together and give it a stitch, or they can place a soft tissue graft. Okay, anything is possible. So ultimately you get this result without waiting, and the amount of resorption that occurs is also very less in this case. Got it? That's called guided bone regeneration. Okay? So you tend to protect. This is the newer methods of protecting the alveolar ridge and even increasing it, augmenting it. Okay? GBR. So remember that. Okay? That is one thing. Hard tissue preparation, you all know. How do you remove your tuberosity reduction, right? You give a crestal incision. Suppose you have tuberosity at the alveolar crest, you give the crestal incision. Reflect a buccal flap, reflect a palatal flap, right? And reduce the tuberosity wherever needed. Got it? If it is a soft tissue, you just have to excise the soft tissue portion of it and give a suture. Okay, now tori removal. Now you are guys, all of you know, you have maxillary tori, mandibular tori. One question is, maxillary tori is more common in whom? Males or females? Females. Aruna is right, it is females, not in males. It's 20% in females and only 10% in males. Okay? Remember that. Okay. So this is just I'm showing you how do you do the removal of the exostosis, right? Here, can you see this? Mandibular tori, right? So you just give an incision, clavicular incision, reflect it, expose the tori, use your burr, remove it like this, or use your osteotome and remove it, and this is what you get. Suture it up and it's normal. Surgical site. See, this is 4 weeks after surgery. There is no inflammation, there is nothing. So 4 weeks after surgery, after a tori, it's perfectly fine. Got it? Okay. Now maxillary tori, as you guys remember, has to be removed in pieces. You cannot remove it in en bloc like you do for mandible. The reason being, there are chances that you might perforate the nasal floor. Okay, you remember the picture in your textbooks, surgery textbooks? You divide it into those squarish pieces, right? And then you remove it piece by piece, right? Yeah, the reason being, there are chances you might perforate the nasal floor. That's not a problem. Mandi. So Mandi, you always do an en bloc resection. You remove it en bloc. 4 to 8 sections, Saurabh. Yeah. Okay. So this is another picture of mandibular tori. I guess you got the picture. See, here it is. You give this vertical incision and 2 Y-shaped incisions. Expose the parietal mucosa. This is the tori. You make it into pieces like these, 4 to 8. And then remove it piece by piece using an osteotome and then suture it back. Simple, right? Okay. So this is the double Y incision, a single middle, I showed you, right? Single middle vertical incisions and 2 Y-shaped incisions. And you section it. Okay? Moving on. A splint or a stent is fabricated before surgery and you place it so that you prevent hematoma formation. Basically, in the palatal region, you prefer to place a stent so that you allow the accumulation of fluid or whatever after surgery to drain. You place a stent, keep it open, allow it to heal. Yeah, a lot of MCQs. So it's actually the same old MCQs. How many sections, and you do it for maxi or you do it for mandi, which is more common in males or females. They're the same old things out here. Nothing new. Okay? So soft tissue, you can have hyperplasia, inflammatory lesions, epulis fissuratum, abnormal frenal attachment and muscular attachment. These are the soft tissue abnormalities that you usually see. Okay? Now, soft tissue reduction for tuberosity. We saw the hard tissue reduction. Reflect the flap, use your bone rounger, use your burr and remove it. Soft tissue, what do? You determine how much you're going to remove by either a panoramic X-ray or use of a sharp probe after your local anesthetic infiltration. See how much of it is necessary and how much of it should be removed. Once you determine that, all you have to do is, see this, can you see this? This is excess soft tissue. So you just want to remove it. They have removed it and sutured it. Got it? You guys are not sleeping, right? Okay, fine. Just bear with me for another 15 minutes, we'll be done. Okay? So epulis fissuratum, you all know it's because of the irritation caused by the denture surface. Right? Ill-fitting denture, poor oral hygiene, fungal infection. Most of the times when you talk about epulis fissuratum, you always say that it doesn't need treatment. We say that it regresses the moment you remove the irritational factor. But the problem is if it is very big, it keeps on growing bigger and there's no chance of it to regress fast or no chance to regress at all, you have to undergo a surgical treatment. Okay? Okay, see these things here can actually be allowed to regress by themselves. But if you have a huge one, you may have to reconsider surgery. Okay? See, proper denture adjustment eliminates reduces the condition. But if surgery is indicated, superficial to the periosteum. Always you try not to touch the periosteum of the bone, because always remember, if you reflect the periosteum, if you touch the periosteum, resorption will definitely occur in that part of the bone. So anything that you do, you try your utmost not to touch the periosteum. Always a supraperiosteal flap, a supraperiosteal incision is always advocated. Okay? See, sometimes you're doing a laser ablation with a carbon dioxide laser also is being tried out. Electrocautery is being tried out. That is only coming to the fact that it's not a very huge mass. Got it? If it's a huge mass, you cannot use electrocautery because it will produce excessive scarring. Obviously, electrocautery is going to produce excessive scarring. It's better to have one clean excision and a suturing. Okay? Okay, see, this is huge, right? Even this. So it needs surgical intervention. Now labial frenectomy. Okay. Now in this, apart from how to do it and what is important, everything which you guys know, I'm going to tell you there are three main methods. What you have to remember in frenectomy is you have three main methods. You have something known as a cross diamond incision, a Z-plasty and a VY-plasty. Heard of it, right? All of the three. Now cross diamond is done when you have a very fleshy frenum. A very fleshy frenum, you need to do a cross diamond. It's huge. Remember, cross diamond, that means you have to have a huge frenum. Right? Now Z, remember when you write Z, imagine it to be a short one. So when you have a short vestibule, okay, and you have a broad frenum, Z, remember Z, it appears broad and short, right? So a broad frenum and a short vestibule, you have to do a Z-plasty. Okay, and V and Y, the letter V and Y itself suggests length, right? So if you want to lengthen the area, then you have to go for VY-plasty. So basically you have three types. You have the cross diamond, you have your Z, and you have your VY. VY is lengthening, Z is when your frenum is broad, vestibule is short, and Z is, your cross diamond is when you have your fleshy frenum. Got it? So that's the only three things you need to remember about entire frenectomy. Got it? You know the problems, everything. Anindya, you didn't understand? What exactly you didn't understand? VY. Okay. When you're writing Y, it looks as if you're lengthening it, right? Length. You're talking of V and Y. Length. Right? So that is done when you want to lengthen that particular area, that frenum area, if you want to lengthen it. The area, I'm not talking of the frenum. Frenum you are going to remove it. But that area, if you want to lengthen it, you're going to use the VY-plasty. When your vestibule, the space is short, and the frenum is broad, you go for Z. Z is short and broad, right? When you write Z. Right? And cross diamond is huge. That means you have a fleshy frenum. Remember it that way. Got it? Everyone clear with it? Okay. So we'll move on to next. See, this is just how you do it. Basically. It will affect your speech, your denture, everything. You guys know it, right? Okay. Now we come to the topic where you have to literally listen to me for 5 minutes. Okay? We are talking of vestibuloplasty. That means you want to lengthen your vestibule. See, either you augment your ridge. See, always you know that the area, surface area matters a lot when retention is concerned with your dentures. Do you agree with me? More the surface area, more is the retention. Agreed. You have two ways of increasing the area. Either you do something about the bone, the ridge, especially mandisoma, exactly, it resolves at a very fast rate and it hardly has any bone left by the time the patient usually comes to you. So in mandible especially, what you do is either you augment the bone, right? You give it bone grafting, place a rib or anything, try to increase it, ridge augmentation, extension, everything. Or you do something about the soft tissue. The vestibular area, try to pull it a little down. That will automatically increase the bone height. Can you imagine that? Are you getting it? The vestibular area, try to make it a little lower, the sulcus, so that automatically the bone height is increased. So we are concentrating on the soft tissue part. We are talking of vestibuloplasty. So we have two things. Labial vestibuloplasty, do it on the labial side, and lingual vestibuloplasty. Very, very important for Mandi, because if you recollect, the major amount of retention in a mandibular denture comes only from its lingual side, right? How it goes and attaches to the mylohyoid ridge, all that is what matters, right? So we are talking of basically keeping mandible in view. You're not talking keeping maxilla in view, okay? So labial vestibuloplasty, lingual vestibuloplasty, and so in your minds try to make three columns: labial, lingual and both. Labial, lingual and labial and lingual. Three kinds. So labial vestibuloplasty was originally known as lip switch or transpositional flap vestibuloplasty. Okay? The reason being, you take the flap whenever you open up the vestibule, right, in order to deepen it, you're going to have a flap. So that is taken from the lip and taken from the alveolar bone, the alveolar mucosa. Got it? So labial vestibuloplasty, that's why it was known as lip switch or transpositional flap vestibuloplasty. First time it was given by Kazanjian. Okay, the Kazanjian was the first guy. There are basically 4 guys who have given labial vestibuloplasty and 2 guys who have given lingual. You can remember it that way. 4 for labial and 2 for lingual. The first guy out of them was Kazanjian. What he did was, he reflected only one flap, okay, from the lip. Okay, he removed all the connective tissue, deepened the vestibule, and he put this flap onto the exposed bone. Are you getting it? He tried to cover up the bone. In the process, he left the lip raw. He said that the lip can heal itself by secondary intention, forming granulation tissue, etc. Yeah, he left the lip exposed. So always remember, labial vestibuloplasty, first given by Kazanjian, he left the lip exposed, thinking that it will undergo secondary healing, granulation tissue. Turned out that long-term result was very poor. Because imagine the lower lip undergoing secondary intention healing, you're going to have a lot of granulation tissue, you're going to have scarring. It's going to heal by scarring. So obviously the movement of the lip, lower lip, is going to be affected. Right? You're going to have a contracture. So that was why it was discarded. No one does it now. Okay, because he left the denuded area on the lip. Now Godwin modified it. What he did was, his was a classical lip switch technique. Switch means he switched the flaps. He put the alveolar mucosa flap on the bone to the lip and the lip flap to the bone. Ultimately, he left nothing raw or nothing denuded. Everything was covered. Got it? So Godwin helped to remove this part. The denuded part helped to remove it. He covered it up. See, periosteal flap would cover the lip. He switched the flaps. Periosteal flap covered the lip and your lip flap covered the periosteum. Understood? So nothing was left raw. What Clark did was, he decided that instead of switching, he leave the raw area on the alveolar ridge, on the bone, not on the lip. But that again is bad because it will cause resorption, right? Resorption of the bone, which we don't want. So again, this was not popular, neither was this, because ultimately kept one raw area. Kazanjian kept it on the lip and Clark kept it on the alveolar ridge. So Godwin's was a good modification. He covered both the parts. So you guys got this table? Godwin's. Priyanshu, yeah. Remember it that way. Okay? This was a good modification. Godwin's. Okay, Saurabh, you didn't understand. Okay, fine. See, Kazanjian, see, basically you know what is vestibuloplasty, right? You have your vestibule, you give a incision, you reflect the flap and you remove certain amount of connective tissue or muscle attachment in order to deepen it. Okay? So, Kazanjian, what he did was, he thought, ultimately after doing all of that, removing the connective tissue, deepening it, you need to cover up the flap after your work is done. So what he did was, Kazanjian covered up the flap on the bone. He covered the denuded bone, but he left the lip part raw. Which caused what? Healing had to be done all by itself. Healing had to be done by the lip itself. It had no help. It had to undergo secondary intention healing. That means it had to form granulation tissue, which caused contraction, constricture. So lip was scarred. So long-term result was not at all good. Godwin modified it and he did the classical lip switch. See, when you say lip switch, the word itself suggests that you are switching the flaps. Kirti, I didn't understand your question. Just changed okay, vestibule is deepened by subperiosteal stripping in, yeah, see, everything has its disadvantages, right? This guy, Kazanjian, did it all supraperiosteal. Godwin did it by subperiosteal stripping. So again, there was some amount of resorption, but what happened ultimately was, we are concentrating on the advantage of this. You're not having scarring on the lip. You're not having granulation tissue formation, not having a lot of time for it to heal. But yes, you're having some amount of resorption. Why? Because you opted for subperiosteal stripping and not for supraperiosteal. Okay? You understood? Saurabh, did you understand? Okay. Okay, so moving on to the last guy. One sec. Yeah, see, this is the one. The classical lip switch technique. Can you see this? This portion, this is from the bone. Okay guys, this is put on to the lip here and sutured. This is the lip. This is the bone. And from the lip, what you have taken, the small thing here, is put to the bone and sutured. That is the lip switch, the classical technique. Got it? But generally, when you talk of transpositional flap and lip switch, it's labial vestibuloplasty is what other names for labial vestibuloplasty is lip switch technique and transpositional flap technique. I'm just trying to make you understand the literal meaning. Okay, the diagram. Okay, observe. This small flap here, where the arrow is pointing, was taken from the lip. This is the lip. Can you see this? This is the person's lip. So inner part of the lip, this flap was taken. And from the bone, this is the bone, right? This part. From the bone, this flap was taken. This thing here. Okay? Lip switch means they switch the flaps. This flap from the lip, where the arrow is pointing, was put onto the bone, okay, and this part from the bone, the flap from the bone, was put and sutured to the lip. Can you see this portion sutured here onto the lip? Okay, so may I got it? Okay, so moving on. Yeah, Kazanjian, what he did? Can you see this part? He left this part raw. He just sutured the bone. Can you see the suturing? This is actually the bone, right? He just sutured to the bone and he left the lip raw. That was Kazanjian. Get it? Okay. Clark, what he did was, he left the bone denuded. So this is the lip, right? This flap was raised from the lip. He put it back to the lip itself. Can you see this? Suturing. This is to the lip. The bone is still raw. It's denuded. It is not covered. That was Clark. Okay. Now we go to Obwegesser. Now one thing you should remember about Obwegesser is, throughout this vestibuloplasty thing, Obwegesser is one guy who has given grafts. He uses grafts in all his procedures. You take labial vestibuloplasty, you take lingual, you take combination of labial and lingual. He advocates graft. It's either split skin graft or it is a mucosal graft. Okay? So see, raw area covered by graft. The moment they say graft, always think of Obwegesser. He was the one who advocated graft placement in vestibuloplasty. Okay, raw area he suggested cover it with graft. Now from here, from Troner and Caldwell, we talk of lingual vestibuloplasty. Okay, lingual vestibuloplasty. In Troner's, the dissection was limited to premolar area. And Troner, what he did was, he gave an incision from premolar to premolar. Okay, and the mylohyoid muscle attachment, he tried to push it downward so that he could increase the depth of the lingual sulcus. Okay, and he sutured the flap. That was lingual. Lingual is comparatively easier compared to labial, but you have to take care you do not harm the various glands and lingual nerve. Okay, you getting it? Okay. Now Caldwell, the only difference is Troner went from premolar to premolar. Caldwell went a little further. He dissected from molar to molar with the mylohyoid ridge reduction. In case the mylohyoid ridge was too prominent, which caused unseating of your mandibular denture, he decided that anyway you have opened up the flap, you might as well do some alveoloplasty. Okay, smoothen out the mylohyoid ridge, as well you increase the depth. Got it? So Caldwell combined both and he went from molar to molar. That's the difference. So you remember that, right? Now submucosal vestibuloplasty, not the entire mucosa, the submucosal vestibuloplasty was given by McIntosh and Obwegesser, not only Obwegesser. Okay? Now both a combination of Buccal and Lingual was given by Obwegesser again. He gave a combination, he also gave labial, he also gave submucosal. Okay? See again, because it's Obwegesser's, read this denuded area over the entire ridge was covered by graft and a stent. Got it? Yeah. So he always advocated placement of graft. Okay, so move on. This is something you guys have to learn. Though not the date, you have to learn the names. This is ridge augmentation, superior border, inferior border. Superior border, we are talking of again Mandy, keeping in mind Mandy. Superior border was done, you could place an entire rib, okay, a rib graft. But the problem with the rib graft was, though it was excellent in this placed area, it proved morbidity in the donor area. It was not safe. Okay? But the advantage of a rib graft, taking a rib and placing it, was that it was an entire single grafting. It was not piece by piece. Now when you talk of iliac crest grafting, it is done piece by piece. Okay, you have to fill it, you have to add a little bit of hydroxyapatite crystals, etc. But when you talk of rib, it gives you a clean single graft. But disadvantage is it's very bad for the donor side. The rib cage, it's very bad for the donor side. So it's usually not done. So superior border grafting given by Davis. Inferior was given by Marks and Saunders. Okay. Interpositional grafting. That is, you position the labial or the lingual plate, cortical plate, interpositional grafting in order to increase the length. You raise the lingual plate. Suppose, for example, premolar to premolar area, okay, lingual cortical plate, you give a vertical incision, raise it above, okay. The difference in the height of labial and lingual cortical plate should be filled with your hydroxyapatite crystals. Are you getting my point? That's the interpositional grafting. Got it? Onlay bone grafting. Now the uniqueness of onlay bone grafting is, suppose you have a very good ridge height, but you don't have the sufficient ridge width. See, again, surface area, we are not only talking of the height, we are also talking of the width. So, sufficient width is not available, then you go for an onlay bone grafting. Again, in this, actually, rib graft is very good. Okay? But because of the donor morbidity, we don't use it. But only bone grafting, remember it, it's for the, basically for the width. It also increases the height, but it's basically for the width. Visor osteotomy, always guys remember, you get a question on visor osteotomy. The main question is whether it's a preprosthetic surgery or it's an orthognathic surgery. The answer is preprosthetic surgery. Do not get confused. Okay? It's always visor osteotomy is preprosthetic surgery. You have something known as visor osteotomy, you have something known as modified visor osteotomy. Got it? It's same thing, repositioning your lingual cortical plate and the labial cortical plate. In modified visor osteotomy, what you do is you go right up to the molar area. You give 2 vertical cuts in the molar area for the lingual plate and a horizontal cut in the anterior region. Are you getting it? An horizontal cut in the anterior region and vertical cut in the posterior region, and then reposition it. So that is modified version of your visor osteotomy. Okay? And sinus lift procedure is always done in case of a highly resorbed maxilla where the sinus floor is very, very close to the alveolar bone. So in order to increase the height, especially this is usually done for implants. See, when you're placing an implant, you need sufficient length of the bone, right? So if the patient is already having the sinus floor very, very close to the bone, you need to lift it. Lift the floor of the sinus so that you give enough space for the implant. Got it? That is sinus lift procedure given by Totem. Okay? Okay. So the next slide. See, this is how it is. Can you see this? This is the rib placed here. This was the actual, this is the actual height, so much. On top of it you place a ridge and you give a transosseous wiring. Inferior border grafting is also done. This is the actual height of the patient's mandible. Inferiorly you place the graft either from the iliac crest or from your rib and you go do a transosseous wiring. Okay? Interpositional grafting, you give a horizontal cut here, right, just at the level of your mental foramen, and you fill it up with bone, either from a graft or your hydroxyapatite crystal or whatever it is, bone graft. Got it? And this is the visor osteotomy. Can you see this? The lingual plate is lifted up. Okay, and this difference is going to be filled, this black thing here, the difference between this height of the labial and the lingual is going to be smoothened and contoured using your hydroxyapatite bone fill. Okay? Okay. So done. Happy? So you guys understood something today, or was it too much? Finally, Soumya. Okay, fine. So it's done, right? You understood. Okay. Okay, fine. Actually, just be online because ma'am wanted to take a TMJ class for you, a small class. Okay, I'll just find out whether she's going to take a class or not. So guys, be online, okay?